All right, we are going to move to the back of the book, chapter 20, to talk about compression and edema management. So in next week's lab, we are going to be doing a lot of things. We're going to be doing electrical stim. We are going to have a guest lecture from Janet Todd. She's a certified lymphedema specialist. She's wonderful, has tons of information. A lot of what's in this lecture she will expand on and give us more information about lymphedema and lymphedema treatment in particular, and we will be practicing compression wrapping in the lab. We will also have time in the last lab to wrap up anything that we didn't finish in this lab, including compression wrapping and traction. I do want to make sure that all the people from the Pierce lab get checked off on the traction units when they're in Bellingham. So that we'll probably have the Bellingham lab people work on compression wrapping and the Pierce lab people work on traction, and then in the last lab the Bellingham people will finish up traction and the Pierce people will finish up compression wrapping. So just so you kind of know what's coming up for the lab. So learning objectives for this PowerPoint, and it'll probably be divided up into a couple shorter lectures. I want you to be able to define edema, hydrostatic pressure, and osmotic pressure. So this is review for you from pathophysiology, so that those things should be on the tip of your tongue, hopefully. I want you to describe the roles of osmotic pressure and hydrostatic pressure in maintaining normal fluid equilibrium. And again, we went through this in pathophysiology, so we are going to go through it again. And hopefully it'll remind you. You've had a little time to forget, and then this is going to bring it back in your mind to help cement that into long-term memory. I want you to be able to describe the role of veins and lymphatic vessels in maintaining normal fluid equilibrium, and state 4 common reasons for developing edema. And these are all in the module, of course. So I want you to be able to state 4 causes of venous insufficiency and describe how edema develops as a consequence of venous insufficiency. I want you to be able to describe normal lymphatic activity and state 4 reasons why lymphedema may occur. And I want you to be able to describe the differences between edema and lymphedema and state why a lymphedema therapist is critical in the management of lymphedema. So the information in this lecture will be on the last exam, so you'll have plenty of time to absorb it. I want you to be able to describe 3 functional consequences of edema, how compression reduces edema, and 3 different applications of compression therapy. So some of them we are going to practice in the lab, and I'm going to show you sort of an interesting one in the area of neurorehab. So I also want you, as usual for everything, to be able to state the contraindications and precautions for compression and why these may be potentially harmful. So we're going to talk about the effects of external compression, clinical indications, contraindications, precautions, and adverse effects, and then examples of various compression techniques, and then we'll take that into the lab next week and practice. So the general effects of 3 effects of external compression are: it improves venous and lymphatic circulation, it limits the size and shape of tissue, and it increases tissue temperature. So to improve, the way it improves venous and lymphatic circulation, it increases external hydrostatic pressure. And remember, in pathophysiology we talked about how hydrostatic pressure is a pushing force and osmotic pressure is a pulling force. So it helps push the excess fluid into the lymphatic circulation and out of the venous circulation. So intermittent compression, where you're compressed on and compressed off, can be more effective than static compression, which would be like compression wrapping, because the intermittent compression sort of milks the fluids from proximal to distal vessels, and it encourages the fluid back into circulation. So we'll look at some various types of intermittent and constant compression. So It limits the size and shape of tissue, and this is used when compression garments are used after amputation or burns. So compression is really important in reshaping a residual limb after an amputation, because most of the time after an amputation you're trying to get that person's limb to the point where they can use a prosthetic leg. And it has to be small enough that it fits into the prosthesis. And if the less swelling there is in there, the better off the person's going to be. Compression garments are also applied over burn damaged skin and over edematous limbs. So there are lots of things where compression garments are used, and we'll talk about them. The external compression may increase activity of temperature-sensitive collagenases to control scar formation. So we want to increase the tissue temperature, and that is really effective when people with burns. We want to control the formation of scars so you don't get excessive scarring. So one of the reasons why we want to control edema, especially after surgical procedures or when people have to be immobile, we want to prevent deep vein thrombosis. We want to prevent venous stasis ulcers, where the ulcers develop from stasis of the blood in the venous system. We use it for residual limb shaping after amputation, so you can fit into a prosthesis, and we use it to control hypertrophic scarring, as in burns. So edema is caused by an imbalance between hydrostatic pressure and osmotic pressure inside and outside the vessels. And we've talked about this before. So venous or lymphatic obstruction or insufficiency can also cause edema. So if you have an obstruction, that can cause edema. If you have increased capillary permeability, that can cause edema because the fluid goes from the venous system into the interstitial spaces of the tissues. Immobility can cause edema. Pregnancy can cause edema because there's just that much more fluid that the system has to process. And systemic diseases, and we don't want to treat edema from systemic diseases with compression, such as congestive heart failure. So that's a contraindication for compression. So in normal conditions, hydrostatic pressure is slightly greater than osmotic pressure. So it results in a slight fluid loss into the interstitial space. So the lymphatic system takes up that extra fluid, so it moves through the lymphatic system to the subclavian vein, back to the heart, back to the venous system. So that balance between hydrostatic and osmotic pressure is what maintains your tissue fluid balance. So edema, or swelling, is a result of excess fluid in the interstitial spaces. So when you have protein and macrophage-rich fluid that's pushed out of the veins into the interstitial space, that fluid is called lymph. So lymph doesn't have blood cells like the blood fluid does, except macrophages, but it doesn't have red blood cells. So it's a clear fluid. The lymphatic circulation, the fluid flows into the lymph system because the concentration of proteins in the lymphatics is usually higher than the concentration of protein in the interstitial space. So you get that osmotic pressure of water moving to where there's the higher concentration of proteins. So if you have a change in the protein balance because of surgery or injury, or obstruction in the lymphatics, you can end up with lymphedema, where the lymphatic system is not working, either because of change in the osmotic pressure or obstruction. And in the picture here, you see the one leg has lymphedema, the other one doesn't. And we'll talk about, and Janet will talk a lot about the causes of lymphedema.